what are the key differences, I guess, between the major vaccines that we're seeing?
Well, they all converge on a common principle. They induce antibody responses to the coronavirus's spike protein or S protein. And they also, to different extents, induce T cell responses. So they induce immunity to the same protein, but they deliver the protein to the immune system in different ways. So they're different devices, like having different brands of car. They'll all get you from A to B, but some might be four doors, some might be SUVs, some might be a bus, but they all get you from A to B. It's just that the presentation differs.
And, you know, I want to discuss their effectiveness a little bit because we're seeing two that are approved right now by the FDA.
Here's where we stand. In the USA, there are, as of today, two approved vaccines, Pfizer and Moderna. Both of them are called mRNA vaccines because they're very, very similar in their designs. And they work by, they encode a region, the spike protein region of the coronavirus, and that's delivered as a nucleic acid. It's like DNA. mRNA is like DNA in this purpose. And they wrap that genetic material up in a little ball of fat to protect it. And then it's injected into your arm and it's taken up into cells, and the cells make the spike protein of the virus, and we raise immune responses against it. Most important are antibodies. So they're the approved ones. Now, the J&J, excuse me, the J&J vaccine is being discussed by FDA advisors literally today. It will probably be approved. It's a different design. We have to see if they approve it without any restrictions or put contingencies on it. We don't know. The FDA will decide today, and it will go, or next few days, then the CDC will weigh in. So that's the next one off the block. After that, we have the Novavax vaccine, which is again a different design. It's protein. That's being tested successfully in the UK and is likely to be approved in the UK within days or weeks, and very soon, and will be approved in Europe as well. They have a slightly different approval process, but it's very likely that will be approved in the next few days in Europe and the UK. And there's a clinical trial going on of Novavax in the USA. I'm actually in that trial as a participant. Probably got the placebo with my luck, but it's the way it is. And that's probably going to work, because if it worked in the UK, it will work in America, and then the FDA will review it and they will approve it. It's possible the FDA will actually review the UK data, but we don't know that. The Oxford AstraZeneca one is more controversial. It's approved in the UK. It's had its issues, and it's not clear what's going to happen in the US. There is an ongoing trial. The FDA will look at that trial. It will not look at the European and British data. It will look at the American data, and it will make a decision. It may or may not get approved. We just don't know yet. And they're the 5 leading designs.
With the other ones, is it just like other vaccines that we've seen, a weakened version of the virus that they inject you with? What is that vaccine?
No, they're not that. So the J&J and the AstraZeneca Oxford, and also the Russian Sputnik V vaccine, they're all based on adenovirus vectors, which are common cold viruses of a different family of viruses, but they're based on common cold viruses that are engineered to present the coronavirus spike protein. So when those viruses infect you for a short period of time and harmlessly, they raise an antibody response against the piece of the spike protein of the coronavirus that's put into that virus vector. So essentially, it's a method of getting the same spike protein into your cells, and so we can raise an antibody response against them. They're not identical. They all use different versions of the adenovirus vectors, but the same principle. Novavax is different. Novavax is somewhat more traditional, actually. You make the spike protein in cell culture. They actually use insect cells to make it, but that's a distinction, minor distinction. So they make the proteins in large vats in cell culture systems, in like brewing beer. I mean, huge production vats, and then you purify the proteins from what's produced in those fats, and then you mix it with something called an adjuvant, which is an immune booster, and you inject it in your arm. And then again, once it's in your body, you raise antibodies against it. So like I say, they all converge on the same basic method of raising an immune response to the key portion of the coronavirus, but they do it in different ways.
And when we look at the side effects, what are we seeing? Are they all kind of producing the same side effects? I know, second shot of Pfizer, a lot of people are feeling like they have a cold or feeling run down for a couple of days and then bouncing back. Are we seeing that with all of them? What is going on with that?
Well, they do differ. I mean, all the side effects are overall pretty mild. I mean, a day's worth of headache and feeling a bit feverish and so on is a damn sight better than a few weeks worth of COVID or a few months or even dying of COVID. So the side effects are worthwhile, and they do differ between the vaccines. The mRNAs are a bit fiercer than the other ones seem to be. To the extent that we can tell, because the other ones haven't been in millions of people yet. But these are all mild side effects compared to COVID. There's something emerging now that convalescent people who have recovered from COVID, may only need one dose of these vaccines. This is now being studied much more carefully, and there are papers out today from Britain, there have been preprints from America, and giving one shot of the mRNA vaccines to convalescent people very rapidly boosts their immunity to a high level. So they may not need a second shot. And that reduces, again, the side effects, because the side effects of 2 doses in a convalescent person can kick in quite badly. I mean, again, in the short term, it's a 1-day feeling pretty rough type of phenomenon. So that's going to be looked at now. The FDA is seriously looking at making a recommendation. The French are already doing this, 1 dose for convalescent patients. So the FDA is onto this and will make a decision probably fairly soon as the data emerges.
And I want to talk about the 2 doses versus 1. We're seeing 2 doses, a potential booster shot, potentially with the Pfizer.
The FDA approved them as 2 doses, and they're given either 3 or 4 weeks apart. And that's absolutely the right decision. You need 2 doses of these vaccines to be fully and strongly protected. There's some effect beneficial after 1 dose, but many of us are quite concerned that immunity is just not strong enough after 1 dose, particularly to deal with virus variants. So you really need a strong response, and that will be sustained for a long period of time. Pfizer is now discussing a third dose, a second booster down the road at some stage in the future. It may or may not be necessary. So all the immunologists I talk to, and I'm one myself, say, look, the FDA recommends you get 2 doses in a 3 or 4 week period. No one's going to freak out if it's 5 weeks, if you miss an appointment, but we don't like the 1 dose idea, and I don't believe that the Americans will do this. The Brits are doing this, but I think that's a bad mistake. So get the 2 doses. Now the J&J vaccine that is being reviewed today by the FDA is 1 dose. J&J also have a 2-dose trial that is ongoing in the USA. I personally think the 2-dose will be stronger and will work better because they've tested it in animals and that's what they saw. So the 1 dose is likely to be approved, but I think it may be switched to 2-dose in a few months' time because I think that will give longer protection. The Russians use a 2-dose for Sputnik V, and that appears to work pretty well, actually. The Russians, to our surprise, came up with, I think, the best adenovirus vector design we've seen. But, we're not going to be using that here. The Chinese and the Indians are developing something called inactivated viruses, where they grow large amounts of virus and kill it with chemicals and then inject it into you. That's pretty old technology. It's not being used here, but it is going to be used as the Chinese essentially use their vaccine as a diplomatic tool and make it available to other countries.
And, you know, when we look at the modification, we briefly touched on this in our previous conversation, but mRNA tends to make it a little bit easier to go in and tweak that genome. Are we going to see people doing that? I mean, we get a flu shot every year, that gets tweaked every year. Are we going to see a whole job sector in immunology for tweaking and changing the genome of the COVID vaccine?
We might. It's really too early to tell. But it is being studied. All of these vaccines, you can adjust the composition quite easily. It's not making a new car from scratch. You're just upholstering the leather. You can do this. But again, as I said before, making the large amounts of a new vaccine stock is not as simple. I mean, Pfizer guy said on TV last night that it would probably take them 90 days to produce a very large amount of a new version of their vaccine. And that sounds about right. I'm not going to argue with a senior executive at Pfizer on how quickly he can make his vaccine, but that sounds about right. You can adjust the composition within hours to days, but it will take you months to make a large amount of the new stock. Now, are we going to need another one next winter like the flu model? Again, it's a maybe. Let's see what happens, but it's appropriate to prepare for that, to plan for it. And again, the FDA has been quite wise on this. If there is a new variant, it doesn't need to go through months and months and months of testing as was done last year for the original design. So that the flu vaccines that people can get every year, they're considered to be essentially the same vaccine as last year, but with a very minor tweak. So there is some basic safety data testing, which is right and proper. But we don't have to go through 6 months of evaluation before switching to a new flu shot. And the FDA has said, yes, that's the model they're going to do for any future coronavirus annual boosters. And that, again, it's the right, sensible strategy, but we may not need it. We just don't know for sure at this stage.
You know, we get vaccines every couple of years for, you know, things like hepatitis or tetanus or mumps and measles, things like that, chicken pox. What is the difference between those types of viruses that we just need to get vaccinated every, you know, however many years, and the flu or potentially COVID that we may need a yearly vaccination?
Well, it's complicated. And inevitably that kind of answer is complicated, but viruses differ in their properties. Some mutate more than others. HIV is incredibly variable. Flu is pretty variable. Coronaviruses are kind of variable, but some hardly vary at all. So, the MMR, measles, mumps, rubella vaccine, you get it once, and essentially measles protection is for life. You get it once as a child, it's not a problem. Others, wane a little bit. You can get shingles later in life and as the vaccine immunity wanes. I mean, but again, it's multiple decades. But a virus that varies, like flu and coronavirus, you then need to adjust the composition of the vaccine so that to enable the immune system to catch back up. So that's one factor. But the immune response to different pathogens varies as well, and varies between people. So it's all best estimates on available science goes into how vaccine composition is adjusted if it's necessary.
What are immunologists looking at when they are kind of changing that flu vaccine slightly? I would assume similar if we were to see a yearly COVID shot.
Yeah, it's genetic tracking. There's an international, and it is truly international, system for looking at how flu viruses change on an annual basis. And since the flu season is in the winter, and the winter is in Australia and the south in our summer, we get a lot of information on what's going on in the Australian and southern hemisphere winter, which is our summer, and that helps America and the northern hemisphere change the composition of their flu virus for our winter. So it's an international system. And it's not perfect. And the flu vaccines are actually not that effective. I mean, there are ways, I think we're going to learn from the COVID pandemic, ways to improve the flu vaccines. I think we can expect that. It's just not a priority at the moment. But the flu vaccines would work better, for example, if they were given with adjuvants. And there are, a lot of research on the design of tweaking the design of flu vaccines to make them better. So they're absolutely better than nothing, but they're not as good. They're not as effective as the coronavirus vaccines, which, surprised many people when we first saw the coronavirus vaccine results.
And I think that's something that not everybody knows who isn't in, the immunology business. So I think that's incredibly important. And thank you for touching on that. We talk about pandemics in the past, the Spanish flu, 100 years before that, a different pandemic, kind of all this happening every 100 years. But how do we get to the point where we aren't concerned about the Spanish flu anymore?
If you'd asked me 2 years ago, what is the virus that worries all vaccine and immunology and virology people? It's influenza. We were worried and have been for decades about the 1918-19 influenza pandemic coming back. So that was top of our radar screens. And there was all the pandemic planning that was done was about an influenza pandemic. Now, it wasn't that's paid as much attention to, particularly in the Trump administration. They downplayed pandemic planning. They closed down a lot of the agencies and people involved in this. We were not as prepared as we should have been, but all the planning was based on the assumption that there would be a new influenza pandemic that could be as nasty as the 1918-19 one. There should have been more attention paid to coronaviruses after SARS in the early 2000s. There should have been, but there wasn't. But absolutely, there remains a serious fear about a new influenza pandemic, because we saw what happened in 1918-19, and you go back in history into the 1800s and 1700s, there were other pandemics that just not written in written records and are less detailed. So once the coronavirus pandemic is over, there will be more attention paid to influenza pandemic planning, and there will be absolutely more government level capabilities to deal with future pandemics. And then there's the unknowns. There are viruses that exist that have pandemic potential that the public has never heard of, but that are quite scary. So we just hope that they don't ever resurface or become apparent in humans. HIV is still around and is a huge global killer. It's become less of a media issue in the States because in the 90s, it was a death sentence in the 80s and 90s. Now, with the availability of very, very good antiretroviral drugs, it's not curable, but it's treatable. So people still die of AIDS in America. And absolutely they do, but it's just not the media focus, particularly not right now. But the HIV vaccine effort continues and should do, but it's incredibly difficult compared to coronaviruses because the pathogen, the virus, is so much more difficult to deal with. I've been working on HIV vaccines essentially all my professional career and banging my head against the brickest of brick walls over it.
And I know we kind of touched on this, but with the COVID vaccine, in your professional opinion, do you think we will be getting this shot forever?
It's possible that we're going to need to immunize people on a regular basis. But honestly, we're not there yet. We don't know how long the immune protection of these coronavirus vaccines will last because we haven't had long enough to study it. So we don't know if immunity wanes after a year or continues for many years. We'll know that because it will be studied. We will know that in the end, by the end of the year. And we don't know what the future trajectory of the pandemic is. Hopefully, the vaccination, mass vaccination worldwide will make this virus become, if not go away, become not a problem. But we don't know. So the future is something that, if we had crystal balls and we're able to, have some magic way of predicting the future, we'd know all the answers, but we'll learn the answers over time because they're going to be studied intensively. The scientific and public health communities are absolutely onto this and have been onto it all last year.
Is there anything else you'd like to add about anything that we've discussed today?
Take the vaccines when you're offered them because they are the best shot we have at curtailing this pandemic. And, I think we will have a brighter future towards the end of this year. No one knows exactly when, but there'll come a point when the country will go into a mass economic crash because everyone's going to be on the beach and no one's going to be at work.